Hey everyone, welcome back to the Dr. Greg Jones Optimization Academy podcast. And today we're going to talk about why standard IV therapy often isn't enough when the body is burdened by inflammation, toxicity, and chronic illness. My guest today is Kim Look, a returning guest. She's a clinician and an educator who has personally administered over 20,000 IVs and now trains practitioners worldwide as a director of training for Ozone Training Academy. After years of nutrient therapy, she went deeper into advanced ozone treatments and EBOO, one of the most talked about and misunderstood therapies in longevity and detox medicine. So in today's episode, we're going to learn three things. First, why EBOO can change clinical outcomes in a way that traditional ozone never could. Second, what's actually being filtered out during EBOO and why it matters for long haul COVID, Lyme, mold, and other chronic illnesses. And third, how EBOO fits into the optimization and longevity space, right? And who it's for, who it's not, and how to make sure it's done safely. So if you've been curious about EBOO or wondering if it's real medicine or just hype, this conversation will give you clarity. Let's get into it. All right, Kim, welcome back to the show.
Thanks, Greg, for having me. It's a pleasure being here.
It's an honor, and I was telling you before we hit record, you were one of my first podcast guests, and I got to be really honest with you, I wasn't good at it then. I
wasn't either. We've both come a long way.
Yeah, and I'm no Joe Rogan or nothing like that. But before, you talking about winging it, man. I didn't even give you guys a question list. I was like, yeah, we're doing this podcast. You just show up and I got questions, and there was a lot of editing, and it was just like, what's the guy talking about? Now we got good cameras, good microphones, and I gave you a little outline to prepare. So look at that.
Yep. It's official.
It's growth, my friend. So, and that's what makes me happy to do these things. But this is an honor for me to have you here because you've been in this space for a while and always been really, just very gracious to me when I have questions and trying to learn about ozone and then UBI. And here we are into 2026, and I'm bringing EBOO to the practice. But before we get into that, you don't want to let the cat out of the bag. You've been in this space for a while, and by your bio, it's probably more now. I think from the bio, you were at about 20,000 IVs in your career. You might be in the 30s now, maybe more, and that's a massive number. But now you're kind of out of the let me give you some vitamins in a bag and, hey, feel better, see you in 3 weeks kind of thing. You're doing more longevity, just more impactful IVs. What was that turning point for you where it was like, hey, I'm going to get out of the nutrient IV world a little bit more and get into these deeper, more cellular function type IVs?
Well, yeah, so I'm hitting 16 years, so not to bore everybody with that journey, but I actually started out in a very cool place. We were a destination practice, bringing in people from all over the world for mostly chronic disease, and this was long before there was ever franchises or hydration or the simple stuff. This was legitimate IV therapy, and I always say I was raised on high dose vitamin C that was more than it is today. I was raised on ozone and in UBI. It's just the way that the practice was at the time. And so I was just really fortunate to find a place that I was able to start there. But as things have evolved and even things have returned, like right now, like Dr. Suzanne Fury, and she's so good, and she's brought like Procaine back. I learned Procaine 16 years ago. And it's interesting. I think a lot of people who, probably in any profession, who go on decades of being involved, they see some of these things recycle. So that's kind of part of the recycling, but also the growth is now into longevity and so forth. So yeah, my focus now is, you can go anywhere for a hydration IV. You can go anywhere for vitamins and minerals. I think that's great. But from a practitioner standpoint, from a focused practice standpoint, I like to spend time doing IVs that really hit cellular function.
Okay. And that's why I'm glad we're here to talk about it, because we got a really cool topic today. But before we get into it, a lot of people that have watched you and even seen my podcast, even my patients that, and patients of longevity and wellness-based practices know about ozone. And usually most people know that, hey, ozone is this basically an oxygen molecule, has an extra oxygen molecule, and they think about the ozone layer. But from that perspective, they understand ozone is basically you're drawing your blood, you're adding the ozone, and you're returning to the patient, and all these magical things are supposed to happen when it comes to inflammation and immune system function. But EBOO is a different beast entirely. Same but different beast. I'll call it
Same.
that.
I was going to say it's not
Same
entirely
is
different.
same,
It's
right?
same but very different.
Same but different, right? But I want to start with the foundations. What is EBOO?
So EBOO stands for extracorporeal, which just means outside the body, blood, oxygenation, and ozonation. So we're circulating, we kind of hook up an extracorporeal, an outside the body system, like a circulatory system outside your body, but connected to your body that continues to circulate your blood. But we add ozone and oxygen, mostly oxygen, to your blood as it circulates with your own internal system. So it's still ozone, and then there are those devices that add the ultraviolet blood irradiation to that. So you're still getting both therapies. I know we'll get to that later, but we're getting both therapies treating your blood as it continually circulates outside your body, back into your body as well. So it's still ozone. You're still like major autohemotherapy is the old term for that, the original term, and all that means is we're adding ozone to your blood. And EBOO just elevates it.
Okay. Now, I'm glad you brought that up because even when I've done the training and doing here in the clinic here, the MAH for the major autohemotherapy, usually we're treating 120 or 60 cc's of blood up to 120, maybe 180 if you're going really, really high dose. And that's a small fraction of our total blood volume. But from what I read about EBOO, you're going up to 2 to 3 liters of blood in a single session. So clinically, what does that volume shift or that higher volume allow you to do that traditional ozone can't?
Well, this can get into some pretty decent biochemistry and biochemical responses with that question. But at a simpler level, there's a couple different factors that play into it. The volume of blood that you're treating, the concentration of ozone that you're using, and then the total dose of ozone that you're using. And so, yeah, the volume of blood you're able to treat is a huge component and an advancement, elevation in therapy with EBOO. Because it is connected to, it's coming out of one vein and back into the other vein, but treated as it does that. And so it does enable us to treat more blood, because the traditional ways of drawing a bolus of blood, an amount into an IV bag, a syringe into an IV bag, there's only so much we can take out of the body at one time before the body would freak out, right? We can't remove a third of your blood and treat it and then give it back to you. The body wouldn't like that. So in this way, we're able to treat more blood because it continually circulates. And that in and of itself is a very big, again, advancement or elevation, we'll call it, with EBOO versus the traditional way.
Gotcha. So the way I kind of see it, and again, I'm very new to this, and by the end of February, I'll be much more educated in this. But
You'll know everything.
I'm hoping so. But when I look at it, it seems like some of the magic of EBOO seems to be this combination of both filtration and ozonation, right? Where the filtration, you're getting the bad kind of particles out, bad things out of the blood, and you're adding the good stuff, the ozonation. So it seems to be this kind of remove and replace strategy. And is there how do I ask this question here without getting too much into biochem again, but this strategy of remove and replace, does that tend to give us a higher reduction of that toxic burden on the body than just say, let me just remove? Because if we're trying to get toxins out, it seems like, hey, the filtration by itself could do that. So how does ozone amplify that process? Let's ask it that way.
Yeah, I think that is a really important question to ask. And there's a lot of conflicting and also good information out there on how and if EBOO actually does that. So you're referring to the fact that not only does EBOO allow blood to come out of the body, circulate, and get ozonated and come back, but it's going through what is traditionally called a filter. And so by that name, by that definition, a lot of people think EBOO filters their blood. It removes toxins. However, in this case, the filter is repurposed and it's acting more like a diffusion mechanism. It's a more intelligent way to diffuse ozone into blood. And so, by that intelligence, it then enables the body's own filtration systems to function better. That's what ozone has for decades been known to do. It does trigger liver function and kidney function. These filtration systems we're designed with. It creates that micro circulation that gets the body to do its own filtering. And I like to sit longer in that space than the fact that it's actually removing toxins itself. That might be something like therapeutic plasma exchange. But while there is an element of removal in this, because there's actually a waste collection canister that does have a byproduct in it, and whatever might be in your blood circulating is bound to make it into that collection cup or that waste canister. But ozone entered into the blood, it's a larger surface area of blood that's receiving the ozone, and then ozone's triggering these NRF2 pathways, not to get too biochem, but these pathways that actually trigger then cellular detoxification as well as those detox organs.
That's fascinating because I think when people see the EBOO device, the machine, the first thing they may think is dialysis because of the way the device looks and also the filter. And if I'm hearing you correctly, that filter in dialysis, and one of the reasons why it has that name, it uses that dialysate solution, and that creates this gradient that actually pulls that urea and creatinine out when there's kidney failure. But
exactly.
But EBOO, there's no solution. There's no dialysis solution. There's nothing there. And the filter is basically like a giant gas exchange membrane, essentially, so you can get more diffusion. Am I looking at the right way?
Those are perfect terms. This was done decades ago also with the ozone, the Pope of Ozone, Dr. Velio Bacci. He at the time was trying to figure out the perfect gas exchanger. That's exactly what it was called. In a way, a mechanism, again, to diffuse ozone more intelligently than to just have a bolus of blood and a bolus of ozone. While that works well, it was also, again, back to the drawing board, so to speak, of how could we do this better. And so this gas exchange was looked at back then and still to this day could be improved upon for sure. We are just repurposing a dialysis filter. However, we don't use the solution that dehydrates the blood in a patient whose kidneys are not able to filter it themselves.
Okay. That's really cool. And I think it's very important to know the difference here because sometimes and we're going to get into some of the stuff I've seen online, and I've seen some different marketing from it. They're calling it it's like the EBOO. The blood oil change.
Yeah.
I heard that one. I was like, I wonder what Kim thinks about that one there. And it's good marketing, right? And it looks cool and all this stuff. But
yeah, we're always trying to make things relatable, right? Physicians learn things at a very high in-depth level, and we're trying to make this something that the consumer can understand. And so there's analogies to be had there. It's not my favorite analogy because if you think about it, when you get an oil change, they don't put the dirty oil back, or they don't clean it and put the same oil back, I guess that's where it's kind of goes wrong with that analogy. Instead, we're cleaning the blood, but you get your own blood back. We're adding oxygen to it, and oxygen by default will create such healing cascades and better circulation. And then you add that supercharged oxygen molecule into it, and it triggers the body to go create really good things. From a cellular standpoint, from a redox, which just means the antioxidants that are produced by our bodies to deal with some of the oxidative stress. The body knows how to do that. It's called hormesis, which when I first started teaching this stuff was like never a word, and now the general public knows it because that's what cold plunging is. That's what hyperthermia is. That's what exercise is, right? You stress your body a little bit because then the body knows actually intelligently, inherently how to respond to that. So what's interesting also about EBOO that's different from the other ways of doing or ozone therapy is it's a very low concentration. In terms of percentages, if we wanted to parallel that, it is 3% ozone and 97% oxygen that you're receiving with EBOO. And so the trigger, the hormetic trigger in EBOO is actually much more subtle than a lot of these other ozone procedures, even though they're treating less blood. It's a very fascinating concept. So less concentration of ozone means there's less of a hormetic trigger that's more subtle on the body and making it almost a little bit more long-term also.
Okay. So maybe a better analogy is you're at home and you got your water in the sink and you got a Brita filter. And when that water goes, you put it through the Brita filter, you pour the water in, and that water in that, container should be cleaner, but it's still the same water that was in your house. The same water, just a little bit cleaner. So maybe that's a better way to look at it.
Yeah.
So I want to circle back to that collection cup, because that's the thing I also see a lot of people, and they have these really cool videos, and they're like, oh, look at this, came out of your blood, and it's this 12-inch thing. You're like, is that? And they're like, oh, it's a clot. And I'm like, I'm pretty sure that wasn't a clot, because you probably wouldn't be alive. I'm just, like I said, I'm no cardiologist, but I'm pretty sure that's not how that works, right? But they do show these videos with this debris or this sludge like filtering out during the treatment or at the end of the treatment. What are we actually looking at in these videos?
Yeah, Greg, I feel like at first, just the disclaimer is there's still things about this process we don't fully understand. That is actually where I sit in this space, is to hopefully create an environment for practitioners to come together to talk about this and to learn more about it from each other's experiences. We know a lot about ozone, we know a lot about UBI, but this procedure in of itself allows for this extracorporeal view of what might be happening. And yet the testing to really prove it is just not quite there yet in terms of what are we looking at. But there is some common sense and some practical application. I've consulted with cardiologists and immunologists and pathologists, and they all are part of our organization to evaluate some of these claims that are being made. And so unfortunately, you do have to be careful about what is said out there. But can it help the body remove clots? Could it help the body remove excess toxins? Could it help the body remove microplastics? I've seen there's lots of influencers out there, big names, who have had the EBOO procedure done, and they've said microplastics, they've said glyphosate, they've said toxins of nature of like bacteria, Lyme disease, parasites. Like, I think I've seen it all stated that EBOO does that. And does it have the potential to get the body to kick that stuff out? Or the actual blood that's circulating through the filter and being diffused with ozone is actually also, there's a third component. We hear it called a filter, then a diffusion mechanism or a gas exchange. But then also this chamber is hyperbaric. It's under pressure. And so the blood under pressure is going to then expel some of the excess. Now, most of our blood is made up of water. So a lot of what comes out of is water. A lot of what comes out is just natural stuff in the blood, like you mentioned, urea and so forth. And then if you're a person who has high inflammatory markers or might have Lyme markers or Epstein-Barr virus, and we were to test your cup, we would see that in the cup as well. So is each of these factors, filter, gas exchange, and hyperbaric chamber, creating a waste? Absolutely. And what's in that waste is reflective of what already is in your blood, circulating in your blood.
That's a fascinating kind of segue here. And again, I know this is going to be different case by case and person by person, but in general, let's just say you ran someone's labs, they did a series of EBOO treatments. After they're done with the treatments, if you ran their labs again, are there any markers that you see change significantly after treatments?
Oh yes. Oh yes. Like and case by case is the magic wording there. And also I love what you're saying is this is my preference. Let's focus on you as a patient before and after versus what's in the cup because we really care about what's left over in your body. If
Right.
we were to take that pre-test, and it could be all the things you're testing for, it could be those heavy metals, it could be those pathogenic strains, it could be those viral infections, it could be microplastics. We can test for that stuff now. And if you run a patient's blood through that, then do a series of EBOOs and run their blood back through that same testing system, you will see change. You will see change within 2 to 3 EBOOs. I was able to be, I think, one of the first, but for our select group of equipment and patients to conduct the first 2 phases of a clinical trial. And we didn't do any of these fancy labs. We did the basic CBC and CMP and HSCRP and some of the basics. And then with that, phase 2 allowed us to target into more of like a more extensive cytokine panel and so forth. But we saw enormous change in the patients who had done a few EBOO. And by the way, our hypothesis going into that study was, is it not what does EBOO do and how does it work, but is it better than the current ozone and UBI protocols? And the answer was emphatically yes. It does the same thing. It just does it in a more mild sense, but in a more dramatic timing. The outcome with fewer treatments was far surpassing the previous protocols that we had.
Now, that's good because I was going to ask you about this later, but I think it's a great time for it now because we're going to get into some of these more severe chronic cases and a little bit of that. But what about the guys and gals out there that are like, all right, I've done ozone. I feel great with ozone. You guys are talking about EBOO. That sounds really cool. For someone who's not, I'm going to air quote this, sick, if they're like, hey, I want to do EBOO, would you say, this is maybe too much for you? You feel pretty good. Let's just do ozone and UBI. Or can this be something that healthy person wants to optimize? They can get a better benefit from doing EBOO versus just doing a higher dose of ozone.
That's been the fascinating journey for me personally, because initially all I was looking at was the total dose. And that dose of ozone is very high. Remember, that's one of the 3 puzzle pieces that we're looking at in comparison to other ozone therapies. The dose is very high, especially if you were to get into treating 3 liters of blood versus 2, it goes up dramatically. So that dose is high, and I always thought we can't start a patient with that. We can't do a sick person with that. You have to titrate them up through doses, which is pretty typical in medicine of all types. But that 2-phase clinical trial showed me wrong. That actually the subtleties of EBOO were more subtle. I mean, so what we did was we did a 3 treatment protocol, and we did bloods before and after each EBOO for 3 weeks, 1 a week for 3 weeks. And then on the 4th week, we did another blood sample with just a Myers cocktail. And what we saw from week to week was definite change, but it was not dramatic. The dramatic came at the end of the treatment plan, where HSCRP improved by 120%, or GFR improved, kidney function improved by 20+%. But it didn't happen treatment to treatment to treatment, even with that hard or high dose of ozone. So that comes back to that other puzzle piece, which is it's a low concentration of ozone, but over time, it gives us a high dose. And so that low concentration, again, going back to the biochemistry, it actually is a subtle hormetic change. It's not a big dramatic bust through the front door with your AK-7 and your grenades, right? It's more of just a infiltration in the middle of the night, and you don't see it coming.
Okay.
So
I
it's
got
a very actually, again, dramatic in the sense that it does get a quicker response. 1 EBOO is like 10 or 20 of some of these other ozone IVs in terms of how patients feel and also what their labs may show. but it's not going to give the same type of Herxheimer responses in general. It's not going to make people detox so quickly and so fast that they're really uncomfortable. And so to answer your question, it's great for the super sick. It's great for those that feel scared. You, I'm sure, see it all the time, like I do, is people come in and say, I react to everything. I'm super sensitive. You have to give me the lowest dose possible because, and I'm not discounting those people in that phase of disease, but actually, just because EBOO is a high dose doesn't mean they're not candidates. In fact, we have so many clients who the only ozone procedure they have is EBOO, and that's their patient's first exposure to ozone. So again, I was proven totally wrong with this. But it also then applies very well to the anti-aging, longevity, precision medicine. I don't know, I want to drop names, but there's so many pro athletes of all kinds. And it was just on Fox News for Simon Cowell, on Fox News with Kevin O'Leary. One of our clients treats Damon John. I mean, these are very healthy kind of biohacker type, categorically speaking, patients who love the way it makes them feel, but also they have the inclination and the focus, the intent to actually extend their life and quality of life, their health span, versus allowing the aging process to happen the way it otherwise could.
Okay. That's really cool. I know that way if people are listening and like, wait, like there's nothing necessarily wrong with me, but I want to optimize this an option. Sounds the answer is an emphatic yes, but case by case, make sure it's safe. And we'll talk about that here towards the end. Now, you mentioned UBI, the ultraviolet blood irradiation. I said that right. Ultraviolet blood irradiation. Make sure.
You got it.
I got to make sure I get it right here. And so, and when I was reading through some of the literature and some of the training materials, there's the full spectrum treatment, which also does EBOO and UBI. I want to get into that, but is there a step down? Are clinics doing this without the UBI, or do you recommend they combine it to get a more optimal outcome?
So I always have to, the disclaimer is I am absolutely biased to UBI.
Okay. Gotcha.
I have been using it since day one. I have never seen anything but good results. I'm extremely educated on the literature.
Right.
And so I am very biased, just disclaimer there. But EBOO itself was originally designed to just be ozone. And ozone's so powerful. And so I'm not sure I would call it a step down if it didn't have the UBI, but it's definitely a step up to have it. In my opinion, there will be people out there that say combination of those two therapies, particularly for EBOO, can create dysregulation in some ways. But again, going back to the literature, that's not there. In fact, the literature says if we combine these two therapies, we can increase our outcomes. So I was a huge part of developing an EBOO device that includes the ultraviolet blood irradiation. And it's a whole separate animal. It's a separate mechanism. It's a separate set of history and studies, and there's hundreds of them, most of them even coming out of Harvard. I mean, UBI is an American medicine. It is an American discovery. It's an American patent, and that is something that matters to Americans and American doctors. Whereas like ozone has so much European and Central American research, which is so valuable, but we love to see it come from our country because that's where we're at. So it's got such huge benefits, and actually can help regulate and balance what ozone does in terms of that redox mechanism and how we create a little bit of stress with this therapy, but that instigates the body's own mechanism to provide the antidote, basically. And it's got so much good research on autoimmune diseases and just how the body regulates the immune system entirely. And it's so good on infections, especially viruses, which has been so important the last 5-6 years. And so I still, at this point, I've trained close to 400, 500 physicians and nurses with the combo. And we've delivered into the hundreds of thousands of these EBOO procedures, demonstrating safety and efficacy.
Wow. It's really cool. So in many ways, it seems like the UBI is amplifying the outcomes of EBOO, just as it does with ozone. And so now I got to figure out, honestly, Kim, what I'm going to do with my UBI device, because now I have I have my Ozone setup. I have the UBI device, but now I just got the EBOO here. So all the boxes are sitting in the back, right? And if I'm not mistaken, that device. So I'm going to have to figure out what to do with that UBI.
Well, let me tell you. Let me tell you what you're going to do with that. You still get to access the higher concentration of ozone with the other procedures you're doing, the simple IVs. And so higher concentration of ozone means now we're like 70% ozone, 30% oxygen. And that change, that shift, or the complete opposite of the spectrum with concentration is actually really great at targeting acute infections. Yeah, that exchange is actually can now be more targeted for certain conditions that might come in. So I have this situation. I had a patient. We mentioned earlier that I don't have a practice, but actually with all these changes, I've had a practice the last eight months or so. Got back into practice. I'm also still teaching, but got back into practice. I have this patient. He's a holistic dentist. And he was coming in for EBOO because he's into all of it and he wanted to extend life, and he's not even very old, but he wanted to get the benefits. And one day he comes in and he says, I have an allergic flare-up, allergies, seasonal allergies and so forth, or I think I've also contracted some type of viral infection in my travel in Africa. And I said, you know what? Let's not do EBOO today. Let's do the other, just our high concentration ozone therapy, because that's going to target your acute situation better in the moment. And so you now have that ability in your office to target that a little bit uniquely. The evolution of the equipment, we used all of it for everything as we went. But now with this, again, advancement, it does allow you to target things a little bit differently. The other thing is with the EBOO is the reality is a patient has to have two really good veins, and not everybody's a good candidate for that. Even some healthy people just don't have great veins. And so it kind of puts you back into a position of doing the more basic protocol, which is still so useful and effective.
So speaking of veins, there are some people who have two good veins. They're just really small. We have those patients who you got to do the hand or the wrist and all that. If someone has horrible kind of anacubital veins, or more cubital veins or basilic veins, they're not that great. Can they do UBI in a smaller vein, like in the hand? I'm sorry, EBOO. Can they do EBOO in a smaller set of veins, like in the hand?
Yes. And you're so going to be familiar with this and see this firsthand come next month, and by February you'll get your experience. You can do it. There's some little hacks that I use to help those veins perform, and we can change some of the settings. However, your vein has to be able to keep up with the flow rate of the device, and that affects the pressurization of it. So you'll get your experience with being able to identify, is that a vein that will work, or is that a vein that we kind of have to go back to some of these other methods, because it's not worth the fight if it doesn't work out right. The costs and of time and supplies and everything. So it is not just that it's a good vein, but that it's a large enough vein to produce the flow rate and to give up that blood in a way that's going to allow the whole procedure to work the way it needs to.
Okay. So this question, and I don't want you to be like, oh God, why is he asking me this? This is such a big topic. How am I going to answer this? This is huge. So I want you to answer it kind of the way you're comfortable doing it. But there are a lot of people stuck in this loop of these long haul symptoms. That's your long haul COVID, Lyme disease, mold toxicity, these tough cases where they've been to 5, 6, up 10, 15 doctors. And it's like, all right, where the needle's not moving, I'm not getting anywhere. And then they find a practitioner that does EBOO, and then the needle starts to move. They start getting a little bit better. So why does EBOO move that needle for these people who've done supplements and they've done detox protocols and they've done all these things, and then they get to EBOO and it's like, wait a minute, I'm getting better. What's different?
Yeah, let me first, if you will, give a little disclaimer again, is that I don't want anybody thinking that EBOO or even Ozone and UBI is a one-stop shop for everybody.
Oh no. Yeah.
It's not the only tool. Sometimes it can be the tool that pushes somebody over that tipping point and now they start to feel really well. I would never want to say that like the peptides and supplements and other IVs that you're doing were a waste, but maybe EBOO or Ozone and UVI push you over. That said, I also would never want to be in practice without this tool because it is so good for almost everybody and is a big factor into how the other things work. It makes everything else work better. So anything else you're doing is part of your health journey or your treatment plan. Ozone and UV are going to make it better. So that little disclaimer aside, yes, like long haul COVID is become such an interesting topic. And yes, I have a practice treating some patients 2 days a week, and then I work with thousands of providers, and I get to hear how they see it in their practice and what they're doing for it, and how EBOO can make that, again, that tipping point. And again, it can even be the tipping point beyond somebody who's tried other formats of ozone. And it really comes back to that true intelligence of how the ozone is being introduced to the blood. It, again, without, this isn't now biochemistry, but even engineering. But the way it's introduced through the dynamics of that filter diffusion hyperbarics is actually putting or diffusing, I guess, the oxygen and ozone into the blood at a micro level. And therefore it's creating this micro circulation that's able to get into, blood is, I mean, vessels are the freeway, blood's the cargo, right? And every tissue organ system needs that cargo in order to survive. And not only to survive, but to thrive, do well, to heal. And if we can't get the circulation, number one, where it needs to go, and then number two, carry the right cargo, then we just can't heal and repair and get well. And so EBOO, with that intelligent feature and how the ozone and oxygen are actually diffused in the blood, creates such good micro and peripheral, it's always doing peripheral, but micro circulation, that we see even an enormous shift in, and you could explain this well, maybe it's a topic for a different conversation, but it diffuses the cellular products and cellular waste like glucose and heat and lactate. I mean, these are, again, cellular respiratory items that can happen in the moment of an EBOO procedure, to the point where you can use like your Aura ring and somebody can be testing at REM sleep while they're sitting in the chair talking to you.
Wow.
And or they can register an aerobic increase as if they're doing sprints on a treadmill while they're sitting in the chair. You don't see that with the other applications of ozone UV. The second half to your question, I believe, comes down to COVID itself and long haulers and the endothelial inflammation and the immune system dysregulation that it causes. And then we're seeing this influx of turbo cancers and autoimmune conditions or symptoms and reactivation of other viruses like Epstein-Barr virus. And EBOO, this EBOO procedure, again, intelligently allows the body to address those things in a circulatory way, but also an intentional, direct way that the other applications weren't able to get to. And some of this is just, I think we're biologically different than we were before COVID. Like, it just changed us. And again, a tool that's able to get to those levels in the body is really important and significant.
I think COVID socially changed me. Like, I just started being around less people. I was like, this is this is not bad. This is nice. That's just me.
And I've been even lecturing on the emotional component and how that's affecting our physical health, the nervous system dysregulation and components to it, that we're just different now. And it is really nice to have this tool of EBOO that actually kind of came alongside COVID and was able to be developed. Because originally it was developed for HIV patients in Malaysia. And then they got into some cardiovascular things. And then it hits the US and other countries. We're in just our company's in 18 countries with EBOO. And so it's become this worldwide need in terms of the outcomes from the pandemic, but also the desire, right? Our individual desire to not be so victim to that type of thing again.
Gotcha. So one of the things you mentioned earlier was the nerve 2 pathway. And for those that are not familiar with that, it's kind of this master regulator of our body's detox kind of pathways. That's oversimplifying it in many ways, but it's they say if you want to dive into it, and basically nerve 2 is activated, our body starts to produce these antioxidant genes, and that helps us with so many conditions. But a lot of people that are dealing with, they're already kind of working on these detox pathways with either vitamin C IVs or glutathione IVs or even NAD. If they're going to go down the EBOO pathway, can they continue those? Can they stack them? And let me kind of put another wrinkle into this question. Can they do any of those during the actual EBOO process?
Yeah, there is so much synergy to ozone and a lot of the things you mentioned. I think the bigger comment there is that not only synergy, but they're cofactors. The cell and the Krebs cycle require things like vitamins and minerals, specifically magnesium and potassium and B vitamins. And then the antioxidants become a support system to that. It's required. And so if you overheat the cell with something like too much oxygen or ozone, again, the cofactor, the coolant in that system, if we think of it like the engine in a car, is going to be those cofactors. And so it's better to do them together. It's not only can you do them, it's better to do them together. In fact, in my practice, I won't do them without. If you get an EBOO, and many practices are like this, but if you buy or you sign on for a treatment plan including EBOO, it comes with these other things. And some of these are more critical, foundational, like vitamins and minerals, than the luxuries or the add-ons like methylene blue. But yeah, some of those are cofactors, and then the trigger, like you talked about, nerve 2 pathway for detox, and then there's NADH and NAD cycles within the Krebs that again produce respiration and then a waste product. Like there's factors here that need to work together. If you were just to isolate one, you could either overdo it or underdo it. And so yes, if you really want to get the most out of your EBOO procedure, you will be doing some of these other things with it. And that could be IV, that could be supplements. And so my basic Myers cocktails, high dose vitamin C is great versus low dose. They're both great. There's also methylene blue that people talk a lot about. Any type of lipids are very great. Like in IV, we can do phosphatidylcholine. I will say very emphatically that the one thing that you do not want to do during your EBOO is an NAD IV. And ultimately, it kind of goes back to what we were just saying, is anything that you do with EBOO is going to be more dramatically delivered to every little vessel in your body. And NAD already has a very intense reaction that is healthy, but also is very intense. And so when you couple that with EBOO, it gets more intense. There's now other products out there, what's the one? I just lost it for a different term.
The Niagen Plus.
Niagen, is that what it's called?
Yeah, it's the
Yeah.
nicotinamide riboside chloride.
Yeah, that product can be done with EBOO. We've had many clients do that because it's just a different variation of NAD. So, yeah, anything you do, I always tell my patients, you're going to get more mileage out of it, more bang for your buck. And some of those you want to preload. We call it a pre-boo, preload before your EBOO. And some of those things would maybe come post-boo.
Okay.
And some of those you could definitely, to save time, to save, I think times are most coveted commodity at this point, but maybe money too, depending on how it's all put
Mhm.
together. But you can do some of these at the same time. And I will say the one thing that really is energized with EBOO is methylene blue, because methylene blue is photo excited. So I guess I should reverse that. It's not energized with oxygen or ozone in a typical EBOO. It is energized with the UBI component of your EBOO. And
Wow.
so methylene blue is photo excited. It donates and receives electrons at a higher rate, which works at the ATP manufacturing plant in our cells. And so if you do that in combo with any UBI device, and even just low level light therapy, or you sit in a red light sauna or whatever, and you've taken it orally, you're going to get more mileage out of your methylene blue.
Got it. Got it. That's a really cool thing to do. I was recommending that a lot to people, like, hey, if you get on methylene blue, if you got red light available, please do it. So people listen to that, and it's to reinforce that. So we talked about this earlier, and as you mentioned, training practitioners and teaching them how to do ozone and EBOO safely. So for someone who's listening to this, it's like, oh, this sounds great. I want to find a doctor or a practitioner that does this. Because again, I always know that not everyone is in this for the right reason. I've just become a realist in this world, in this space. But if someone's looking and they call this clinic up or call this practitioner up, are there any questions they should know to make sure they're doing this safely? They've been trained in it. This is the right place to be.
I think that the intention is so good across the board. There's a few EBOO manufacturers, like the equipment's manufactured. Each of them have very good trainers, and they go on site, and they really, we're all really collaborating to that degree to enforce safety for the patient, safety for the
Right.
provider, and safety for the medicine. I think individually, though, you'll know if you feel comfortable with that office and
Right.
comfortable with that staff. Unfortunately, you kind of have to get to that point to know if you feel comfortable.
Mhm.
But you can ask for their credentials. You can ask where their device comes from, and if it's something important to you to include the UBI, then that might be a question for you. I would just, watch out for things that sound a little bit too good to be true, like we're removing, 6-inch clots, or we're pulling out, parasites that look the size of worms. Like those are
Mhm.
probably embellished, and really kind of consider it more to be something that's improving your body's own mechanism to do what it's naturally designed to do. And I think if that's the way that your practitioner approaches it from a cellular mechanism, then you're probably on the right track.
That's good. It's good. I always look at that kind of instinct too. If it feels a little pushy, a little too salesy,
Yeah.
like if you can tell me how, the benefits of it, but also you also got to tell me what can go wrong, right? Or are there risks with it? And that's kind of where I want to segue into, because not everyone is a candidate for EBOO. It's not for everyone, right? So are there any specific blood disorders or conditions where it's like, you know what, this is contraindicated. This is not even a direction I want to go with you.
I haven't seen any documentation or literature that says that anything with EBOO is outside of what the contraindications for ozone or UBI already were. And so that list is really short, and it really comes down to some interesting things. If you have any bleeding disorders, or if you've very recently had a heart attack or stroke, if you're acutely intoxicated, pregnancy is definitely one. For medical liability reasons. It just, it's like you just don't want to mess with that. And so the list is short, but the one that people really look out are they're implementing is G6PD deficiency. And if you have it, if you know you have it, then you're lucky. But there's so many people that would not know if they have that, and that's one of the criteria. Many offices they would just want to run that blood test to make sure. And all that means is that you don't have the enzymes that allow for this redox mechanism to happen efficiently, and so they want to proceed with caution. So that G6PD is really the one that most watch out for. But what we further get into is what we call adverse reactions. And all that means is that it's an unexpected reaction. It doesn't mean it's bad. It doesn't mean that you can't recover from it. It's just that we can't predict it's happening. And that list is also really short, but I mentioned it a little bit earlier because there is such a great shift in cellular respiration here. We see a drop in blood sugar, and it's completely mitigatable. Was that a word? Mitigatable.
I would say
Preventable. You can
preventable.
yeah.
I like preventable better.
I like making up
like that
words.
better.
Makes me sound smart or dumb. I don't know which. But you can completely prevent it. So what you really need to prepare for is that you eat right before you come in, like within an hour. And that meal needs to be high in protein and fat. Now, you might also see some of that circulating in your blood if we really wanted to dive into what we see in the tubing and what we see in the cup, but that's far better than some pancakes or some oatmeal or a green smoothie for breakfast, where we know that glycolysis is going to transfer very quickly. And so by the time you sit down with your EBOO, 25 minutes in, your sugars have dropped 40 points. So it's super easy to prevent. Just take it seriously. Eat very good. And I hope any place you're getting EBOO, this is what they tell you. And then they're going to monitor your blood sugar throughout the procedure. And again, it's not generally like a life or death, but it definitely can drop to a point where it's uncomfortable and it takes more time to rebound than it does to just prevent it. So again, that's at a cellular level, your sugar, and again, you could probably dive into the Krebs cycle and respiration of this to a great degree, but sugar is something that, again, our cells process every single second of the day, and it's important that they have it, and this will create a shift quickly. That's the kind of the one I fear the most, the one I manage and work with the most. Again, it's easy to prevent. The second one is a drop in blood pressure. And those symptoms look very, very similar. You just feel lightheaded, you feel a little woozy, you might feel a little dizzy. People say I feel a little weird, or you feel a little sleepy. Not relaxed, but sleepy. And that's because we get such great vasodilation. Your vessels are dilating so well with oxygen and ozone that it creates a drop in blood pressure. And that we can also watch for, and we can also fix. We can fix these things quickly with IV also. You can give some lactated ringers or some saline that's going to bring your blood pressure up, or we can give you some D5W that's going to bring your blood sugar up. And so we can watch for these things, but the more you prepare as a patient, the better that will be. The third thing, which is fairly common because we talked about it a little bit, is just the nervous system in people is just everybody's in at least low grade fight or flight. So when you come in for this procedure, it's a little bit more than an IV, and we see an increase in vasovagal responses, which is your body says, I'm a little stressed out already. I've already hit my limit, and then you're going to poke me 2 times with a needle, and I'm nervous about this procedure, and I'm in a doctor's office, and so I'm going to pass out. And those symptoms look very similar also. Again, they could feel lightheaded, you could feel clammy, you could feel a little extra tired. So those are the main ones that we watch for. Again, all preventable. The vasovagal passing out, syncope, it's mostly, again, related to how well you prepare emotionally when you come into this procedure. So you need to take some time for it. Don't come in rushed. Don't come in right off the 405 freeway in LA and think that you're just going to fly in here, get an IV, and fly back out. Your nervous system needs to be prepared for this, and so do you, both consciously and subconsciously. And so eat, be well rested, take time to breathe, take time for this procedure, carve out the 2 hours, and don't overschedule yourself. And as an office, if you're a provider, I recommend the exact same thing. And just, be centered when you do this, and your veins will perform better, your body will perform better, you will be more receptive to the therapy, and, a couple needle sticks are not going to send you over the edge.
Gotcha. So that was going to be one of my next questions about how long should the procedure kind of be planned for, or should it take about 2 hours if I'm hearing you right? so people can be prepared for that. Now, you mentioned making sure that you're in a kind of a well-fed state. What's your pre-boo meal?
You know what? Those that do the best. I had a guy the other day and he had sardines and eggs for breakfast, and
Oh
his blood sugar
no.
stayed exactly the same all the way throughout the procedure. Do you eat
Okay.
sardines for breakfast every morning?
Nope. We're just gonna have to roll the dice of that blood sugar.
I was
We're
like,
rolling
man,
the
I want to
dice.
be like you someday. They're so great. But,
Yeah, yeah.
yeah, again, I love it when people say bacon and eggs. I love it when people say
Mm,
avocado and, maybe toast or something, but they've got that protein with it. And if it's more like a lunchtime thing, I just don't want to hear, yeah, I ate breakfast 4 hours ago. It's just got to be, so again, usually with some high protein, not just a protein bar, but something that's going to sustain. And like it's got to be relatively close to the procedure.
okay. I'll have a little EBOO menu when they come train me. Like, hey, is this EBOO authorized, or what's the word I'm looking for? Approved meal
Yeah, I
before
mean
that.
it's and you'll
So yeah.
see it. You'll see it when you check blood sugars on people because like I had a
Mm,
guy probably 210 pounds, relatively healthy. This is his fifth EBOO. Relatively healthy because we cleaned him up. He came in kind of a mess with long haulers, but he was 100%, and this was his fifth one. He's like, "Yep, had my green smoothie this morning about an hour ago." And
mm,
his blood sugar is one of those that dropped close to 40 points. And he didn't
wow.
yet feel the symptoms, but because I was checking, I said, okay, we're not going to mess with this. And I gave him some of that sugar IV. And then at about 10 minutes later, he was like, oh, I didn't realize I was feeling funny until you help me rebound. And that was a green smoothie, which by all intents and purposes is a very healthy breakfast. Had a lot of good stuff in it. It just wasn't enough to get him through the EBOO procedure.
So before I let you get out of here, there's a question I have to ask. So another treatment that a lot of people have heard about that they may think is similar to EBOO, but I want to make sure we can clear this up, is TPE, or therapeutic plasma exchange. How does EBOO compare to TPE?
Yeah, I love both. I think that you can't go wrong with either one, but they are different. And I usually explain it as therapeutic plasma exchange is a mechanical detox, and EBOO is more of a biochemical detox. We talked about it so much already. The EBOO and ozone UBI, they instigate the body to do its own detoxification, literally triggering nerve 2 pathways and liver processes and kidney processes and so forth. It also does a lot of other things like immune modulation and targeting infections and so forth. And therapeutic plasma exchange is actually, that's why we say mechanically removing plasma. And the thought is that plasma is carrying, it contains these toxins or antibodies or inflammatory proteins. And so if we remove your plasma and we replace it with improved or cleaned plasma, which is a donor plasma, people need to realize that. Like EBOO sticks with your own body's stuff and you get it back. The good stuff anyway, you get your blood back. Therapeutic plasma exchange is actually you're replacing it with something else. And that has been tested and been proven and shown, et cetera, to be cleaned. And then now you've literally mechanically removed those things from your body. It is very much a procedure, just like EBOO. There's a hefty device, and your doctor needs to go through lots of training with it, etc. And there's no oxygen or ozone involved with therapeutic plasma exchange. Or UBI. So you're removing those tools, but again, truly mechanically replacing your plasma.
Okay, gotcha, gotcha. Just want to make sure we have the difference. Because I actually did a podcast a couple weeks ago with a guy who does a lot of TPE, and it's kind of great that we're doing this episode too because I don't have a dog in that race. After February 20th, I will, but for now, I don't. And so, a dog in the fight, rather. So now it's good to have that
Well, I
opinion and
can
talk
tell
about it.
you that
So,
I've got clients who have both. And
mhm,
those clients who have both will say, we love both.
Yeah.
again, whether it be the millionaire that wants to live forever or is just trying to stay on top, or the pro athlete or the everyday person. That's what I love about these things, is they're available to the everyday person and they're affordable to most people now. But their treatment plans, their thorough treatment plans, no matter your focus as a patient, longevity or treatment, is to do both, because they're
Yeah.
different. They cross over and enhance each other, but they're not the same. If you had to choose, I don't know how I would choose one or the other, except maybe that
Yeah.
component of, do you want your own or do you want, something donated? And that's maybe more of a moral, ethical thing with each patient. But
Yeah. And then we get to have that conversation with those patients. And I kind of have this, I'm probably going to be one of those clinics that has both, because I also recognize that TPE is significantly more expensive than EBOO. And maybe the person is like, look, doc, I got $1,000, $1,200. I can definitely support that with my financial circumstances. I can't do 10K a treatment at this point in my life. So at least I have an option that can help you get better. But then it may be hey, your condition is more severe. You've been dealing with this for a long period of time. Your labs show me this. You may be more of a TPE candidate than an EBOO candidate. And to start with, and maybe they start with TPE, get better, and now we maintain with EBOO. So I think there's going to be a lot of options for us in the future.
yeah, and I agree with what you're saying. I mean, there's some patients that maybe you need to start with a clean slate. They don't have enough support within their system at this point to really just help the body do its own thing. They need to actually start with a new slate.
Yeah, that's good to know. And there'll be options out there. Okay, so this is great here too. So before I let you go, because this has been great, and first I want to say thank you for your time and making time for this. And I know we were trying to figure out our schedules to record, and we're here, and I'm extremely happy about that, because EBOO is a topic I wanted, not just because we're bringing it to the clinic, but I also want to get more education out there so people can know about it. But for those listening that want to know more about you and your work and your training programs, where can they find more info?
Yeah, so you asked me this very first question was what transitioned for me. And really, I decided that I can help a lot of people in practice, but if I can teach providers better information and good tools, then I can help even more people, right? It's exponentially bigger. And so the last 10 years, I've been teaching to providers only. So if you're a patient listening, then you definitely can refer your provider to me to learn and to understand ozone and UBI and EBOO and all things IV actually better. If that's something you would love you love your doctor, you love your location, you just don't offer this yet, you can send them to me. If you're a practitioner listening, you can find me at ozonetraining.com. And so, again, we teach providers. We want these therapies to be safe. We want them to be effective. And we help you get the equipment as well with whatever you're looking for. So ozonetraining.com is my website. Kim Look at ozonetraining.com is my email. And I answer every email myself, even though there's hundreds a day. And at this point, there is an EBOO directory. That's a culmination of all of the manufacturers. And so again, you'll have to sift through that based on what location might work and which EBOO procedure they have favored. But there is an EBOO directory to find an EBOO provider. And it's called
Awesome.
EBOO. You want me to share it?
Yeah, you can, because all this stuff I'll put in the show notes too. So I think that'll be great for people to have.
Yeah, and I would recommend you get on there. Again, it's hosted by a man who has no skin in the game for EBOO. He feels like it saved his life, and so he wanted to make the service more available to everybody by creating this online directory. But it's eboomedical.com.
Okay, got it. And we will have all that in the show notes for people to follow up with. So it's good to know where to go and where to look. Well, this has been great, Kim. I truly appreciate you. Like I said before, are you going to be at Calm this February?
I'm still trying to work out my schedule for January and February, but I hope to be.
Okay. Well, I'm sure I will run into you in person again, and we'll have to, after I get my EBOO device up and running and I'll get some more clinical case studies and some more data, I may say, hey, let's do this again, because now I got some cases to talk about and actually do like a really cool, maybe case review kind of podcast. So that'll be fun.
Yeah, I'm so excited for you. So excited for your patients. I think you're going to love it, and you'll see such changes in your patient population bringing in this tool.
I'm excited. I'm excited.
Me too.
All right, everyone. This has been another episode of the Dr. Greg Jones Optimization Academy. I want to thank you all for tuning in, for listening, and for supporting this podcast. And if there's anyone out there you think that would benefit from the information, not only in this episode, but the episodes we've done in the past, please share this with them. And until next time, let's stay optimized.